early good morning to my partner, Dr. Ashish Prasad from Arizona, who has joined at 2:30 in the morning his time. It's a great pleasure to be at TCT India, South Asia 2021. Welcome to all of you for this edutainment program where you can actually enrich yourself with the program that Dr. Srinivas Kumar and his team from Facts India Foundation has created. And without further ado, I ask my colleague and my co-chair, Ashish Prasad, to say a few words before we go on to the main program.
Hey, thanks, Ramesh. It's a pleasure to join the meeting and be part of this. Looking forward to some really exciting case presentations over the next few hours and a very lively discussion that we're anxious to be a part of and learn from each other. So without wasting too much time, let's get the show going.
So we would like to invite Dr. Ganesh Kumar now to start the proceedings of this program.
Thank you, Ashish and Ramesh. I'm the first presenter, and I've been asked to show one of my case, which has a significant LVOT calcium. So this is a case which we had done in the month of November last year. And along with me, Dr. Pudamia from Rich Candy was there for this case. Most of the cases actually we do together. And my other colleagues, Dr. Irfan and Dr. Rishikesh. This is an 86-year-old lady, diabetic, and she started having dyspnea. She's a lady who's with her son in Mumbai and has been doing all her household activities during this COVID lockdown without any mates and help. And she started observing a gradual decline in her NYHA class. And just a few days back, they tried doing a phone consult with me, and I couldn't make out anything on the phone consult. And they suddenly came one of the days to the ER with class 4 symptoms. She was in frank heart failure with saturation of 88%, blood pressure of 110/60, bilateral extensive creps, and a very soft systolic murmur in the aortic area. The ECG showed an LBBB with a PR of around 170, 180 milliseconds. And we did a quick bedside transthoracic echo, which showed a degenerative affection of aortic and mitral valve. There was a severe aortic stenosis with aortic valve area of 0.34 centimeters square with a mild AR. The dimensional index was very significant, and there was a marked LV hypokinesia globally with a paradoxical septal motion with severe LV dysfunction of 20 or less than 20% rather. The gradient was just 20 millimeters of mercury given the LV dysfunction, and there was a significant pulmonary hypertension. This was the gradient. Hardly the LV was contracting. I could say that it was like 20%. So patient was, that evening patient was stabilized in the CCU with anti-heart failure measure. She was put on non-invasive ventilator. And next day she did come off the non-invasive ventilator, and that's when we took our chance and did CT angio on her. The risk evaluation showed a STS score of 12.8. So obviously there was no other way other than a TAVR that we could have offered to her. The CT scan showed the area of interest here is look at the LVOT with almost a dense blob of calcium protruding well into the LVOT, which continues from the annulus. The area was 430 millimeter square, almost close to the 26 valve or a high 23 valve. Coronary heights were all right, and there you see the calcium distribution on the leaflets. We didn't have the coronary anatomy so far, though the left main looks calcific here. So we thought whenever we'll take her for TAVR, we'll do a angio on table. The groins look okay with scattered calcific plaques on the right side. The right side looked more favorable than the left side. We obtained a high-risk consent and also need for a permanent pacemaker given the LVOT calcium. And the angiography showed just a moderate lesion in the circumflex. Otherwise, there was no significant coronary artery disease. Patient was sedated, intubated, and kept on elective ventilation. Temporary pacemaker was inserted, and bifemoral accesses were obtained. The interesting part of this is you see the aortomitral continuity. Again, I would like to run this image again. You see the calcium, if you can appreciate the dense calcium in the LVOT. Crossed the left ventricle, wasn't a problem in crossing the valve. Hemodynamics obtained on table showed hardly a gradient of 20 millimeters of mercury. Given the LV dysfunction, we didn't want to challenge with nitroglycerin. We accepted this gradient as her true gradient. We pre-dilated with 20 mm Sapien balloon that comes with the 23 valve. The idea was to take a 23 valve with 1 cc extra, and so that we do a dilatation only once and come out rather than trying to under deploy and going in again with a balloon and dilating given the LVOT calcium. This is the pre-dial. And then one important thing I want you to notice is the position of the valve, the Sapien 3 valve. We wanted to get a 90-10 deployment in this. So we did place it quite high than the usual 80-20 that we've been doing it. And we almost obtained a 90-10, 95-5, you can say. This was the image, the transthoracic, the intraprocedural transesophageal echo rather, and we didn't see any perivalvular leak after deployment of the valve. We were quite happy with the pictures that we had obtained. And you see the position of the valve, it looks quite high, like almost a 90-10, almost avoiding the LVOT calcium. Post deployment with a single full dilatation, taking 1 cc extra. This is the hemodynamics we obtained. We are happy with it, with no PVL. And this is the next day echo. I mean, you see already the LV function has picked up to 30%. And this is 1 month follow-up actually. I just put it here so that you can see how well the LV has picked up a month's time. So our learning points in this particular case specific to the LVOT calcium that I was asked to present today is our preference of valve has been Sapien 3 in most of our cases, especially in cases like this, where we wanted to achieve a high valve deployment. Like we showed you how we achieved a 90-10 deployment, avoiding the LVOT calcium. That will help us to prevent the need for a pacemaker and other complications associated with LVOT calcium. We go very gradually, sustain inflation, try to feel the calcium and keep a continuous look at the LVOT calcium while deploying it, and try to avoid post dilatation in these type of presentations. Hence, we took 1 cc extra in this, though we took a valve which was 23 and not a 26. So that's how we planned this case. So I'm open to discussion.
I think that's to just try a valve that's new to you based on LVOT calcium. I don't think is a smart idea, because if you're uncomfortable with a valve platform, you don't want to be trying it out for the first or the second time on a case like this in an 86-year-old with poor LV function. That's number one. Number two, her annular area was about 440, if I remember correctly, or maybe 410, he said.
427,
right? Yeah, 427 is, she's at a 23 millimeters with a Sapien 3 Ultra with the skirt would put us at about a 3.3% undersizing. With the degree of calcium she had in her leaflets as well, I think anchoring and perivalvular leak were not going to be a concern, which was proven by the fact that they didn't really have to go crazy with a 23. Having said that, we all know that there are predictors of calcium, and there are areas of calcium that I worry about more in terms of risk of annular rupture. And I know there was this nodule that extended on the non-coronary cusp, which is the most common location of where the calcium does extend into the LVOT. But the extent of calcium in this case was not as much of a concern, especially given the fact that you were using a 3.3% undersized 23 millimeter valve. And I think your deployment was very good. The 90-10 technique is helpful. Having said that, I'm not sure that matters as much, because with the Evolute R, we can also now, with the cusp overlap technique, which you probably will hear about at the meeting in the next day or so, also can mitigate the need for pacemaker, and your accuracy in landing the self-expanding prosthesis can also be greatly enhanced. So I'm not sure that the 90-10 mattered as far as the need for a pacemaker as far as choice of valve, but in this case, I think I would have gone with a Sapien 3 just for the reasons you did, even though we have familiarity with both. In an 86-year-old pacemaker prosthesis mismatch, or patient prosthesis mismatch, and a 23 versus 26, quote unquote, for a small annulus is not going to matter. She's not running a marathon tomorrow. All she needs to do is get back to her house, be able to do her activities of daily living, her housework, live with her son, and spend the rest of her life without being admitted to the hospital. So I think for all those reasons, it was an excellent choice and a great demonstration of how to deploy a Sapien in the presence of LVOT calcium. Thank you.
Wonderful job, Dr. Ganesh Kumar, and your team, to Kirti and everybody else, and Irfan. Excellent. I think now we'll move on. Yeah, any comments, Dr. Ganesh Kumar?
No, thank you for your comments.
Thank you.
I appreciate it.